1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's,
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, when you step onto a medical surgical floor for the very first time, for clinicals, the environment, it kind of tells you exactly what to expect.
Oh, absolutely.
Yeah, like you hear the steady beep of the heart monitors, you see the IV poles lined up everywhere, and the goals are just incredibly concrete.
Right, you're there to fix a physical problem.
Exactly. But then, you know, you transition to your psychiatric mental health nursing rotation.
Yeah.
And the monitors are just gone.
They're completely gone.
The IV poles are gone. The whole landscape shifts. And honestly, for a student, it can feel really mysterious, a little anxiety-inducing, and just completely different from literally anything you've trained for so far.
It's a massive paradigm shift. I
Yeah.
mean, you are moving from a space where illnesses can, usually be seen on an X-ray or a lab report to a space where the primary instrument of healing isn't a scalpel or a syringe.
Right.
It's you. Like the nurse is the actual intervention. And that shift is exactly why we're doing this deep dive today.
Yeah, so consider this your elite mentor session.
Yeah.
We are pulling directly from a huge stack of foundational psychiatric nursing textbooks, the DSM-5 TR, and some really fascinating evidence-based practice notes on housing and public health.
It's a lot of material.
It is a lot, but our mission today is to act as your mentor and extract like the highest yield 20% of this content, the stuff that gives you 80% of the understanding you need for safe patient care.
Exactly. We're going to break down the history, the systemic realities of hospitals today, and the clinical mindset you absolutely must master before you ever step foot on the unit.
So to start that journey, I feel like we have to establish a baseline, right?
We do, because if we want to understand mental illness, we first have to really define mental health.
Right, and the World Health Organization has a very specific way of defining it.
They do. They don't just call it the absence of disease. That's a huge misconception.
Yeah.
The WHO actually defines mental health as a positive state of physical, mental, and social well-being. So it's this proactive, really dynamic state.
It's not just a light switch. You aren't just, healthy or sick.
Yeah.
I kind of like to think of it more like a dynamic ecosystem where all these different elements are constantly interacting.
That's a great way to look at it.
Yeah, because you have your individual factors, right? Like your biological makeup, your genetics, your personal emotional resilience. And then you have interpersonal factors like your ability to communicate and find intimacy.
Right.
And crucially, and we'll talk about this a lot today, you have social determinants. Things like housing, poverty, systemic discrimination. If one part of that ecosystem experiences like a drought, the entire environment shifts.
It adapts, yeah.
Exactly. And sometimes it adapts in ways that cause real suffering.
And that ecosystem analogy is so essential because it really illustrates how subjective and how culturally dependent mental health can be.
Oh, for sure.
I mean, what one society views as a perfectly acceptable adaptive behavior, another society might view as entirely maladaptive. So because of that cultural variance, determining what actually constitutes a mental illness relies on a very specific clinical threshold.
Which is what?
Well, we look for behavior that causes significant personal distress or behavior that significantly impairs a person's daily functioning.
Okay.
That impairment is really the tipping point.
But if mental illness is that subjective, like if it's that culturally influenced and tied to personal distress, how does the medical field standardize a diagnosis?
A great question.
Right. Like how do you create a clinical rule book for an ecosystem that's always changing?
Well, the medical field relies on a diagnostic framework.
Yeah.
And in the U.S., that framework is the DSM-5 TR.
The Diagnostic and Statistical Manual of Mental Disorders.
Exactly, which got its text revision in 2022. And it serves three main purposes for the mental health field.
Okay, lay them out for us.
First, it provides standardized nomenclature.
Meaning?
Basically, it creates a shared language. So a clinician in New York and a clinician in California are talking about the exact same clinical picture.
Oh, that makes sense.
Right. Second, it presents defining characteristics to differentiate symptoms. And third, it assists in identifying the underlying causes or, the etiology of these disorders.
Okay, but let me push back on this for a second. Thinking from the perspective of a student nurse listening to this, it is entirely outside of your scope of practice to officially diagnose a patient.
Absolutely.
You are not writing the prescription, and you're not making the official DSM diagnosis. So why dedicate so much time to understanding this massive, dense manual?
It's a really valid point.
Yeah.
But while you, as the nurse, won't make the medical diagnosis, the DSM is essentially your roadmap.
Your roadmap for what?
For understanding the comprehensive reason for a patient's admission. It guides your nursing judgment. And furthermore, the DSM doesn't just list psychiatric disorders in a vacuum.
Right.
It actually lists medical conditions that affect the mental state. And, most importantly for nursing care, it lists psychosocial and environmental problems.
Oh, wow. So it actually flags real-world issues.
Exactly. It flags if the patient has severe housing issues, economic distress, educational deficits, or even legal problems that directly affect their prognosis.
So it brings us completely back to the ecosystem analogy.
Yes.
Because if a patient is admitted for severe depression, your nursing care plan is going to look radically different if you know they're being discharged to a really supportive home environment versus being discharged to a homeless shelter.
Precisely. I mean, you cannot treat a patient effectively if you just ignore the environmental realities they're navigating.
Yeah.
Understanding that holistic picture is the absolute core of clinical judgment and safe patient care.
Okay, but if the diagnostic manual is explicitly telling us we have to look at a patient's housing and economic distress to understand their illness, we have to ask the big question.
Let's hear it.
Why are psychiatric units absolutely flooded with patients facing these exact environmental crises? Like, how did the system fracture this badly?
Well, to understand that, you have to realize that the history of psychiatric care is essentially a history of systemic extremes.
What do you mean?
Well, going way back, like in ancient times, mental illness was often viewed through the lens of divine displeasure or demonic possession.
Right.
Aristotle believed it was an imbalance of the four humors: blood, water, yellow, and black bile.
Which led to all those awful physical treatments,
That's
right?
right.
Like bloodletting and purging.
Exactly. And by the time we reached the Renaissance in England, institutions like the Hospital of St. Mary of Bethlehem were literally charging the public a fee to come in and view the patients as if they were a sideshow.
Ugh, it is just horrific to think about.
It really is.
And it wasn't until the 1790s that we saw a real period of enlightenment. Like, you had advocates like Dorothea Dix in the United States campaigning for asylums.
Yes, Dorothea Dix was monumental.
And it's funny because we hear the word asylum now and we immediately cringe. But back then, it literally meant a safe refuge.
Exactly.
She advocated for nutritious food, warm clothing, and actual shelter for people who were otherwise just left to freeze in the streets.
Right. But unfortunately, those state-funded asylums eventually became massively overcrowded and severely abusive themselves.
Yeah.
So the first real modern turning point didn't happen until around 1950 with the boom in psychopharmacology.
The medications.
Yes. The introduction of drugs like Thorazine, which is an antipsychotic, and lithium for mania, they completely altered the ward environment.
How exactly did those medications change the physical space of the hospital, like for the nurses working there?
Well, before these medications, the wards were chaotic. I mean, staff relied heavily on physical restraints and seclusion just to maintain basic safety.
Wow.
But Thorazine reduced the positive symptoms of psychosis.
Yeah.
So the severe agitation and the hallucinations. By calming those neurochemical storms, patients could actually engage in reality.
Oh, I see.
Which meant staff could suddenly engage patients verbally. It shifted the environment from essentially a holding pen into a space where actual therapeutic intervention was possible.
And that sets the stage for what I think is the most massive systemic shift in the history of mental health care. In 1963, the U.S. enacted the Community Mental Health Centers Construction Act,
Right.
which basically launched this massive wave of deinstitutionalization.
And, the goal behind deinstitutionalization was incredibly noble.
Right. On paper, it sounds great.
Yes. The idea was to move patients out of these restrictive, isolating state hospitals and transition them into community-based care, allowing them to live closer to their families.
Makes sense.
So federal funding shifted, commitment laws became much stricter, and patients were released en masse.
The structural failure here, though, it reminds me of taking a deep-sea diver and pulling them instantly to the surface without a decompression chamber.
That's a really stark analogy, but it's accurate.
Right. The environmental change is just too rapid because the community centers that were supposed to act as that decompression chamber providing outpatient therapy, medication management, and housing support. They largely never materialized.
No, they didn't.
The funding simply did not follow the patients into the community.
It didn't. And so the patients suffered the bends, basically, resulting in rapid clinical decompensation.
Yeah.
And this brings us to the most critical systemic issue you will face in practice today, the revolving door effect.
The revolving door. Let's dig into that.
So when deinstitutionalization occurred, the number of public hospital beds was reduced by 80%.
Wait, 80% fewer beds.
80%.
Yeah.
But at the same time, admissions to those remaining beds skyrocketed by 90%.
That math alone is staggering. The system simply cannot absorb that kind of volume.
It can't. So it creates this continuous high-speed flow of patients. Because of managed care and severe insurance limitations, a patient might only stay inpatient for 3 to 5 days.
3 to 5 days for a severe psychiatric crisis.
Exactly. And during that brief window, you might stabilize them slightly. But psychotropic medications often take weeks to reach therapeutic levels.
Right.
5 days is nowhere near enough time to equip them with the coping skills needed for community living, let alone address co-occurring issues like substance use disorders.
So they are discharged without the necessary skills, they often lack community support, they inevitably decompensate, and they end up right back in the hospital a few weeks later.
The revolving door.
And the sources highlight that in some cities, emergency department visits for acute psychiatric distress have jumped 400 to 500%.
It's a crisis.
Patients end up just boarding in the ED for days, sleeping on stretchers in hallways, just waiting for an inpatient psych bed to open up.
It represents a severe safety risk for the entire healthcare system.
Yeah.
And it bleeds directly into the crisis of homelessness.
How so?
Well, approximately 1/3 of unhoused individuals have a severe mental illness or a chronic substance use disorder. Homelessness actively worsens psychiatric problems.
Of course.
And those severe psychiatric problems make it nearly impossible to maintain stable housing. It's just a vicious cycle.
Okay, so you're taking all of that history, the systemic pressure, the underfunded community resources, the revolving door, and you're dropping a first semester nursing student right into the middle of it.
It's intimidating.
It is entirely rational to feel intimidated. And the source material outlines the exact fears students face going into these clinicals. So let's tackle those head on.
To ground this, we look back to 1952 to a pioneering nursing theorist named Hildegard Piplau.
Piplau, yeah.
She established that the therapeutic nurse-client relationship is the crux of psychiatric nursing.
Which is hard for students to grasp at first, because in MedSurg, you're actively performing visible interventions. You start an IV, you read an EKG, you change a really complex dressing.
Right.
In psych, from the outside looking in, it looks like you were just having a conversation. How does a student recognize that they're actually providing a clinical intervention?
You have to completely reframe your understanding of action. In psychiatric nursing, the communication is the procedure.
The communication is the procedure. I love that.
Building trust is the intervention. So let's look at the internal anxiety students bring to this. The most common fear is, what if I say the wrong thing?
Oh, absolutely.
Students are terrified of ruining a patient's progress with just one clumsy sentence.
I can easily imagine a scenario where a patient is crying, a student just really wants to comfort them, and they accidentally say a cliche like, everything happens for a reason.
Oh, yes.
And they immediately regret it.
That happens all the time. But the reality is that there is no magic phrase that will instantly cure a patient. And equally, no single clumsy statement is going to permanently ruin their life.
Right.
Your primary tools are genuine interest and active listening. If you stumble, you simply use your humanity to recover.
How do you do that?
You pause and say, that didn't come out right. What I meant was, I am here and I am listening. Honesty and transparency build far more rapport than aiming for some kind of clinical perfection.
That's great advice. Now, another major internal fear is the feeling of prying. Students worry that asking personal questions is just invasive.
And building on what we just discussed about rapport, timing is everything.
Okay.
You don't walk up to a newly admitted patient and immediately demand they explain their deepest childhood trauma.
No, definitely not.
You establish baseline trust. Once that therapeutic relationship is formed, asking difficult questions to assess their suicide risk, their home environment, or their symptom severity, that's not prying.
Right.
It's a necessary clinical assessment to keep them safe.
Okay, let's shift from those internal communication anxieties to external threats. because safety is a massive concern.
It is.
Students wonder if their physical safety is in jeopardy on a locked psych unit.
We have to actively unlearn what popular media teaches us about mental health facilities.
Yes, please.
Media coverage highly exaggerates the link between mental illness and violence towards others. Statistically, patients are far more likely to hurt themselves than they are to hurt you.
That's a crucial statistic.
However, strict safety protocols are paramount.
What are the concrete safety interventions a student must practice on the floor?
Always position yourself in an open area rather than a closed room when speaking with a potentially agitated client. Ensure you have clear access to the door.
Okay.
Give the patient plenty of physical space so they do not feel cornered. And here is a major safety red flag for students. You must never try to physically restrain a patient yourself.
Ever.
Never. If a situation escalates, your intervention is to step back and call for the staff who have specialized crisis de-escalation training.
That makes total sense.
Huh.
So physical boundaries dictate your physical safety, but what about professional boundaries?
That's the other side of the coin.
Let's say you're walking onto the unit for your shift and you recognize a patient. It's a neighbor or maybe someone from your nursing cohort. How does a student handle the limits of confidentiality in that specific moment?
Given the stigma that unfortunately still surrounds mental health care, this is a highly sensitive situation.
Yeah.
Confidentiality is absolute. If you recognize someone, you immediately notify your clinical instructor so you can be reassigned.
Some students might think the best approach is to just hide from the patient or pretend they didn't see them. Why is that the wrong move?
Because simply ignoring or avoiding the person can induce severe feelings of paranoia, shame, or rejection in a patient who is already in a really vulnerable state.
Oh, I didn't think of that.
Yeah, they might wonder, did they see me? Are they going to tell everyone at school? The clinically sound choice is to briefly and professionally speak to the person.
What do you say?
You reassure them that you're glad that you're getting care, that their privacy is entirely safe, that you will not look at their medical records, and that you will be stepping completely away from their treatment team.
So you alleviate their anxiety before removing yourself.
Exactly.
Managing those boundaries requires a tremendous amount of internal regulation. If your primary intervention isn't a physical procedure, if your communication and empathy are the tools of the trade, then you are the instrument.
You are.
And an instrument has to be constantly tuned.
Which brings us to the concept of self-awareness. It's defined as the active process of recognizing your own feelings, beliefs, attitudes, and biases.
Right.
You cannot safely help a patient navigate their complex internal world if you are entirely blind to your own.
This gets complicated fast, though. What happens when a nurse's core moral beliefs completely clash with a patient's lifestyle or choices?
It happens.
Let's say a nurse has a deeply held personal or religious belief, and the patient's actions violate that belief entirely.
This is a foundational nursing concept that governs professional ethics. You do not have to condone a client's views or behaviors, but you must accept them as a worthwhile human being in order to provide safe, effective care.
Okay.
The source text uses a really stark example. Think of a nurse who is morally opposed to abortion, who is assigned to care for a patient who just underwent one.
How does the nurse separate their personal ideology from their professional duty in that moment?
As a professional, that nurse must separate their personal beliefs from the patient's immediate healthcare needs. The nurse's internal feelings cannot dictate the quality of care, empathy, or medical attention the patient receives.
You're there to treat the patient in front of you unconditionally.
Unconditionally.
But building that level of separation and self-awareness, I mean, that doesn't happen overnight. How does a student actually practice this?
It takes deliberate intention, and the evidence points to a few actionable strategies. Keeping a reflective journal is highly effective.
Just writing it down.
Yes. You write down your clinical experiences and force yourself to identify the specific emotions a patient triggered in you.
Okay.
Engaging in formal clinical supervision is another method. Even top-tier veteran psychiatric nurses sit down with supervisors to discuss challenging client interactions and unpack their own personal biases.
Crucially, you shouldn't beat yourself up when you uncover a bias. You are human. The goal isn't to become a blank, unfeeling robot. The goal is to acknowledge the bias consciously so it doesn't subconsciously steer your clinical judgment or negatively impact the patient.
Accept your beliefs as part of who you are, but manage them professionally. That is the true essence of therapeutic distance.
Well, as we wrap up this session, let's look at the foundational knowledge you now possess. You understand that mental health is a dynamic ecosystem. not just the absence of disease.
Right.
You understand the systemic history, how the shift from state asylums to underfunded community care created the revolving door of short hospital stays and emergency department boarding. You know how to navigate those initial clinical fears by focusing on genuine communication, strict safety boundaries, and the psychological reasons behind them. And you know that your own self-awareness is your most vital piece of clinical equipment.
You have the baseline required to understand the environment you are walking into. But, before we conclude, I want to circle back to something we discussed at the very beginning. How social determinants, specifically homelessness, actively exacerbate mental illness. There's a fascinating concept emerging in the evidence-based practice notes regarding how we build environments.
Oh, yeah.
It is called trauma-informed design for housing.
We talked about how the environment impacts the mind, but how does architecture actually treat trauma?
Well, we know that a vast majority of unhoused individuals have experienced severe trauma alongside their mental illness.
Right.
Trauma-informed design suggests that we physically engineer public housing to promote psychological healing based on neuroscience.
Wait, really? Like, how?
We're talking about architecture that incorporates abundant natural light to regulate circadian rhythms. We're talking about specialized acoustic dampening to eliminate triggering urban noise and mandatory easy access to green outdoor spaces.
That reframes the entire approach. I mean, what if the physical architecture of our communities could become the next major systemic intervention for unhoused populations suffering from mental illness?
It's incredible to think about.
Imagine treating the ecosystem directly instead of just trying to medicate the biological symptoms after the environment has already caused the damage.
It forces future nurses and healthcare leaders to ask a bigger question. Are we only responsible for treating the patient on the unit? Or do we need to start advocating for the environment they're discharged into?
It is definitely something to mull over the next time you look at a city skyline. And absolutely something to keep in mind as you begin your clinical rotations. You are entering a field where you have the power to influence that ecosystem, one patient interaction at a time.